Hey, and welcome to this first video for the lecture series Anatomy and Physiology. My name is Wally. I'm the current Director of Medical Operations at Emory's Medical Center, and I'll be discussing the nervous system with you. As I said, this is the first video out of a series of approximately 10 videos. These videos will be quite long, and you won't have to remember everything right now. You do have to know some general concepts, and most of these concepts will return when you study different diseases or pathologies. So although a lot of this might not necessarily be clinically relevant right now, it will be useful information later for when you'll actually get to see patients. So let's dive in. The learning outcomes for this lecture are the classification of the nervous system into subdivisions, important structures in the central and peripheral nervous systems, functions of the cerebrum and cerebellum, functions of the brainstem, functions of the spinal cord, functions of the cranial nerves, action potentials and saltatory conduction, proprioception and nociception, autonomous nervous control, and finally neurotransmitters and autonomic receptors. Now, a lot of these terms might be, or you might be unfamiliar with a lot of these terms, but we will discuss them throughout this video. If you ever feel like I'm going too fast, don't feel afraid to pause the video, or perhaps there's methods to slow this video down, because that's a remark I often receive. So let's start. First of all, one of the ways in which we can classify or kind of subdivide the nervous system is by dividing it into a central and a peripheral nervous system. Now, the central nervous system is composed of the brain and spinal cord, whereas the peripheral nervous system is comprised of the spinal nerves, which are the nerves that you see right here. These are spinal nerves. Then you have the peripheral nerves, which you do not really see in this image, but for example, this part is a peripheral nerve. And the cranial nerves, which are nerves that are found in the brain that are also part of the peripheral nervous system. And these this is the most important classification and subdivision of the nervous system, although there are more. Another one is, for example, left and right, because for some functions and some sensations, the left part of the brain controls the right side of the body. This depends on the type of activity that you're talking about, and it also depends on from what location of the nervous system your activity has stemmed from. So for now, it's important to know that, of course, there's a left part and a right part of the brain, and therefore a left part and a right part of the body in terms of nervous control. Then there's motor and sensory. So motor refers to physical actions like movement, and not just voluntary movements, such as the movement of your jaw while you're talking or your legs while you're walking, but also involuntary movements, such as your bowel movements or your lungs or your heart. Muscle contractions are also controlled by the motor system. Then you have the sensory division, which is the division that feels. So it's how you sense things. And it's not just active things that you sense, such as touch on your skin or room temperature, but also things you do not actively but passively feel, such as your blood pressure, your heart rate, or the presence of certain chemicals in your blood vessels that can cause certain functions. More on that later. And the final way in order to classify the nervous system is by somatic and autonomic. By somatic, we mean that something is under, at least predominantly, voluntary control. Your arms, for example, or at least the muscles in your arms, are part of the somatic nervous system. And the reason why is because we can contract these muscles voluntarily. You can voluntarily choose to move your arms. Your autonomic nervous system controls activities that you do not directly have to control. You have autonomic control over your heart rate and blood pressure. You also have some autonomic control over your nervous system, although of course parts of the muscles with which you breathe are also somatic muscles because you can voluntarily also choose to stop breathing or to increase your respiratory rate. And your intestines, for example, are also controlled by the autonomic nervous system because, again, you do not actively contract your muscles in your intestines. So let's then go on to some important structures that you can find in the nervous system. First of all, we have the cerebrum, which is the largest part of your brain, or essentially it is what we often refer to as the brain, which is this entire part. And then we exclude this part over here, this kind of reddish brown part. So it's these four large lobes actually together on both sides. So on the left and right together, it's called the cerebrum. And the cerebrum consists of a couple of lobes, which are the frontal lobe, temporal lobe, parietal lobe, and occipital lobe. We more on the lobes a bit later. There's also the cortices, which is the plural of cortex. The cortex, or a cortex, is a small part of the outer layer, the outer about half a centimeter of the brain. And two important cortices to remember are the somatomotor cortex, which is over here and located in the frontal lobe, and the somatosensory cortex, which is located over here and in the parietal lobe. And now it doesn't show in the image, but in the middle, this line is often referred to as the central gyrus, or central sulcus, sorry. Over here, you can see the insides of the brain, where you can, for example, see the corpus callosum, or the pituitary gland, or the hypothalamus and the thalamus. Those are not important for now, and those are mainly discussed during the lecture on endocrinology, so about the hormones. So the cerebral cortex, I've already referred to it a bit earlier, and the cortex actually consists out of a couple layers. It's about 2 to 4 millimeters thick, which is about half a centimeter. And in terms of inches, I don't know how many inches it is, but you would have to calculate that for yourself. But there's essentially 6 layers. Now you do not have to memorize all of those layers, of course. This just contains descriptions for all of them. But the most important layer for you to understand right now is layer 5, which contains the Betz cells. And the Betz cells are also known as pyramidal cells. They are very large neurons, which are nervous cells, and they control a lot of different functions. So they can send out signals to the outside, and they can send out signals to the inside of the brain. So layer 5 contains the Betz cells. I promised you guys I would talk about the different cerebral lobes, so here we are. First of all, the frontal lobe, which you can see is at the front over here. That's why it's called frontal lobe, which has a couple of functions, namely mainly some motor functions, particularly in this somatomotor cortex, but there's also other regions in the brain or in the frontal lobe that control motor functions. And not just the movement of your arms and legs, but also, for example, when you have to do repetitive actions like repeatedly writing or repetitive moving of objects, your brain can remember this. So your brain has some sort of motor memory in the frontal lobe as well. And the frontal lobe is also important for language and decision making, which is important to note because patients with dementia, or at least something called frontotemporal dementia, which is where it mainly affects the frontal lobe and temporal lobe, those patients often have a lot of emotional disturbances as well. And the reason why language is also involved in the frontal lobe is because Broca's speech center is also located in here, typically on the left side. And the Broca's speech center is responsible for your control of speech. And it's located in the frontal lobe, crossing with the parietal lobe. So the temporal lobe controls memory. It's a very simple function. The reason why we call it temporal lobe is because it comes from the Latin tempus, which means time. Parietal lobe, the reason why it's called parietal lobe is because it comes from the Latin paries, which means wall, and it's essentially just the side wall of the brain. And it's involved in a lot of different sensory functions, as you can also see with the somatosensory cortex, and also with speech. And finally, there's the occipital lobe, which has a lot of small functions, but the biggest function that the occipital lobe has is, and the most important one, is vision, because this is actually where the optic nerve stems from, which is the cranial nerve that supplies nervous input and nervous back loop from the eyes. Okay, so now that we have the lobes, let's talk about white matter and gray matter. So you often hear about this, and you might see pictures of this on the internet, such as this picture. Note that in the brain, the gray matter is on the outside, whereas the white matter is on the inside. But that in the spinal column, or in the spinal cord, I should say, this is the other way around. The white matter is actually on the outside, and the gray matter is on the inside. So, what does the white or gray matter actually mean? Well, the gray matter is where signals are generated. So this is where the cell bodies of neurons are located. More on the structure of a nerve cell a bit later. And white matter is not meant for generation of signals, but transmission of signals. So here you can see that the signals are actually generated in the cortex, which is that gray layer, and they are transmitted by the center of the brain. And then they are transmitted along the, well, outside of the spinal cord. And on the inside of the spinal cord are cells that can also still generate signals. Then we have the neuroglial cells. So before we move on to the other organs or parts of organs in the nervous system, we will first discuss some neuroglial cells, which are cells found in the peripheral nervous system and central nervous system that exert certain important functions. And these are not nerve cells, so they cannot actually transmit signals, but they have other functions to help the nervous system. So in the peripheral nervous system, we have the satellite cells, and the satellite cells help with the structure of the brain, and also it is thought that it also has some function in nutrients of the peripheral nervous system. And you also have the Schwann cells in the peripheral nervous system, which provide something called myelin to the neurons. And myelin is kind of a fatty substance that will increase the speed at which a signal is transmitted along a neuron. More on signal transmission and also more on which nerves are or are not myelinated later. These are cells that are specific to the peripheral nervous system though, and there's other neuroglial cells specific to the central nervous system. So instead of the Schwann cells, the central nervous system actually has the oligodendrocytes. The oligodendrocytes are small cells that are actually able to cover one neuron with multiple sheaths, whereas a Schwann cell is only able to make one cover of a neuron. And with a cover, I mean one of these kind of blocks. Then we have the astrocytes, and the astrocytes are kind of like satellite cells in the central nervous system, although the astrocytes can provide more functions. The astrocytes provide nutrients, they provide support, and they provide structure to the central nervous system. The microglia are specialized immune cells, and they help in preserving the immune protection of the brain. They can fight off infection, and they can cause inflammation to actually fight off this infection or to fight off other foreign molecules that can be found in the nervous system. And then finally, the ependymal cells are the cells that are found mainly in the inside of the brain and around the spinal cord. And the reason why is because these produce something called cerebrospinal fluid, or CSF. Cerebrospinal fluid is a type of fluid that is found around the brain and spinal cord. And what it does is that, when you, for example, jump up and down, you have this huge movement to your brain. And if you didn't have this fluid, you would literally be kicking your brain up and down. And you don't want that. So this layer of fluid actually kind of dampens that kind of pressures, those kinds of pressures and movements. So that's what the fluid is for. All right, so now we've had the cerebrum, which was this large part, and now we've come to the cerebellum, which is this small part over here. It's divided into three lobes. So we have the anterior lobe, we have the posterior lobe, which is largest, and then we have over here the flocculonodular lobe, which contains of the flocculus, which are the sides, and the nodulus, which is the middle. Now, it's not important to know exactly how this is structured. What is more important is, of course, its location, but also its function. So the cerebellum is involved mainly in balance and coordination, as well as motor learning and precision. So when you have a little baby and you have them grab a tiny object like a toy or like a stuffed animal, you will perhaps notice that when they move their hands towards the toy, it doesn't go as efficient. They'll kind of try to grab it by swinging their arms around, and if they then happen to catch it, then that's a win, I suppose. Now, if adults were to do that, you would consider that abnormal, but you wouldn't consider it abnormal in children. And that's because their cerebellum is still being developed. So when you get older and when you get more experience with grabbing things, you will learn to be more precise. And that kind of motor learning occurs in the cerebellum, among other regions, of course. It's also thought that the cerebellum has some role in the development of language and emotion as well, although this is still rather precarious. So then we have the brainstem. And the brainstem is the location found actually adjacent to the cerebellum, perhaps, but below the cerebrum. And it consists of a couple of parts. Over here, you see the pons, which is this kind of round. And below here, you see the medulla oblongata. I think the spelling of those words was found in an image a couple slides earlier. I think the slide about the cerebrum. The brainstem has a lot of different, mainly autonomic functions. And it's very important that this structure remains preserved in the nervous system, because the brainstem actually controls why you are here and breathing and why your heart is beating. Because what it can do is it can actually control your blood pressure, heart rate, and respiration. Those are a couple of the most important functions that it has. But the brainstem also controls some forms of muscle contractions, voluntary and involuntary. And it also controls hunger and sleep. So the brainstem is something you want to be really careful with. Then there's the cranial nerves. And the cranial nerves are, with a total of 12, quite important to study. Now, I do not expect you to know all of them out of your head already. I'm going to cover them like this, and when you cover your neurology study material, or when you ever decide to study some things about neurology, you will have to be familiar with these cranial nerves, especially with how to examine these in the cranial nerve exam. So there's 12, and I will go over all of them very briefly. So for the first one is the olfactory nerve. And the olfactory nerve, what it does is that it provides sensory supply to the nose. In other words, it gives you your sense of smell. Then there's the optic nerve, which is the second cranial nerve, and it supplies sensory input and output to the eye. In other words, it helps you look, it helps with vision. Then there's cranial nerve 3, which is the oculomotor nerve, which supplies, I think, the majority of the eye muscles with motor innervation. So it's mainly a motor nerve and not a sensory nerve. That in contrast, of course, to nerves 1 and 2, which were sensory. Then we have the trochlear nerve, which is nerve 4, and it controls a couple of important eye muscles as well, although few, which is the superior oblique muscle. Then there's the fifth cranial nerve, which is the trigeminal nerve, which you can see down here. And the trigeminal nerve has some sensory functions and also some motor functions. So the sensory functions are sensation of the face and the teeth and oral cavity mainly. And the motor functions is that it helps in mastication. And mastication is a very, very difficult word for chewing. And there's cranial nerve 6, which is called the abducent nerve, or abducens nerve. And it also controls one of the eye muscles, which is why cranial nerves 3, 4, and 6 are often paired together, and that during the cranial nerve exam, it's relatively easy to control the function of these nerves, because you just ask patients to move around their eyes. Then we come to cranial nerve 7, which is the facial nerve. And the facial nerve has a couple of functions too, but it's primarily just muscle control of the face. The facial nerve does not have any sensory outputs. Then we have cranial nerve 8, which is called the, where do we have it? I cannot seem to find, oh, there, the vestibulocochlear nerve. And it's a sensory nerve, and it actually supplies sensory inputs to the vestibulum and the cochlea. And the cochlea is, of course, for your sense of hearing, and the vestibulum is for your sense of balance. So this is where hearing and balance are controlled. Then there's cranial nerve 9, which is the glossopharyngeal nerve, which is on the top right over here. And it is also a combined nerve again, so it has both sensory and motor input and output. So the motor output is that it controls pharyngeal musculature, it says on this image. And what it essentially means is that it controls some contractions of the back of the tongue, but also swallowing and all the muscles that have to do with that. And it also supplies sensory inputs to the posterior part of the tongue, which means the back part of the tongue. And actually, when you put your finger here, that's when you get your gag reflex. So the gag reflex is predominantly controlled by this nerve. And it also controls sensory inputs of the tonsils and the pharynx. Then we have cranial nerve 10, which is the vagus nerve. And the vagus nerve is very, very important for the autonomic nervous system. And it has, well, I would suppose, most functions out of all of these cranial nerves. And it's also the longest because it actually dives into all different kinds of body organs. So I would suggest it's the longest. And it also has motor and sensory functions. In the heart, lungs, gastrointestinal tract, and also the neck, head, and ear area. The motor and sensory functions of the vagus nerve are related to the autonomic nervous system, in particular the parasympathetic nervous system, which we'll discuss later. Then there's cranial nerve 11, which is called the accessory nerve, which is responsible for contraction of a couple of muscles found in your shoulder, and they help with shoulder contraction. Finally, there's cranial nerve 12, the hypoglossal nerve, which controls most muscles of the tongue. So the anterior 2/3 of the tongue are, in terms of motor, controlled by the tongue. All right, so now we've discussed that. Then we come to the spinal cord and the spinal ganglia. So as I said, the spinal cord, of course, has the white matter on the outside and the gray matter on the inside. And what's also important to know is that there's kind of these rings on the side of the spinal cord. And that's what we call the dorsal and the ventral root. Now you have to understand that the dorsal part, which means the part that's closest to the back, because the dorsum is Latin for back, and ventrum or venter is Latin for organ, which are typically in front of the spine. I would hope they're in front of the spine. So the ventral root is in control of motor functions, and the dorsal root is where the sensory nerve enters the spinal cord. So what happens is that over here there are free nerve endings, for example, which are receptors, and they recept pain, for example, and then it transfers along or transmits along this sensory neuron, goes into the spinal, into the dorsal root. Over here you have the dorsal root ganglion, and the ganglion is where the nerve cells actually collect, which are connected to this, and they help transmit the signal. And then it ends in the middle, and in the gray matter, you have these neurons called interneurons. And inter is Latin for between, because it literally is a neuron that's in between the sensory and the motor neuron. So after the signal is transmitted from the interneuron to the to the motor neuron, it travels through the ventral root and outside, and then goes to its effector organ. For example, when you feel pain in your hand because you're sticking your hand into a fire, your spinal reflex will be to get your hand out of that fire because that hurts and you probably shouldn't do that. All right. And these ganglia are part of the autonomic nervous system. And depending on what part of the autonomic nerve system they're either close to the spinal cord or they're far away and close to the organ that they actually innervate. So if they are close, this is called the sympathetic chain, and these are the sympathetic ganglia. So the sympathetic nervous system actually has the ganglia pretty close to the spinal cord, whereas in the parasympathetic nervous system, which is the parasympathetic autonomic nervous system, these ganglia are found close to the effector organ. More about the autonomic nervous system at the end of this presentation. And then there's the meninges, and the meninges are also important to be familiar with. So the meninges are kind of relatively thin layers, so thin sheets that are covering the brain, and they are important for protection. Now, as I said, they are rather thin, so I mean the skull is probably the biggest layer of defense, but still the meninges play an important role because they actually make sure that the brain is actually somewhat distant from the bone, because otherwise a fracture to the bone would instantly mean injury to the brain. Whereas now it doesn't necessarily have to mean that because there's this fluid space and there's also these small layers that still protect the brain. And the meninges are called the dura mater, the arachnoid matter, and the pia mater. Dura mater means the thick, or it means the tough mother. Arachnoid means, of course, spider-like, and it's because of the spider webs that are located between the arachnoid and the pia mater. And pia means pious, or in other words, calm or thin. So this is the thinnest layer. Then you have the arachnoid layer, or the spider web layer. And then there's the dura, or the thick layer. Now here we have the structure of an actual peripheral nerve. So imagine that, of course, from the spinal cord, this nerve gets smaller and smaller and smaller, all the way until it's just a little tip, and then it connects back to either a receptor or it connects to, for example, a muscle. That's where nerves typically end, or in a receptor, of course. And this is what they are structured like. So this is an entire nerve, and the entire nerve is covered by something called epineurium. And inside of this nerve are smaller fascicles, which contain small nerve fibers. These fascicles are covered by something we call perineum, or perineurium. And when you take one of these nerve fibers, this nerve fiber is covered in endoneurium. You have to be familiar with those terms. Nerves also contain very small arteries and veins, although the biggest arteries and veins are typically located alongside a nerve and not inside the nerve itself. These are just to supply blood alongside the small nerve cells. So there's also different pathways in the nervous system. So I mentioned the motor and sensory functions of the nervous system, and they have different tracts along which they follow in the spinal cord in order to exert their functions. I will cover all of them in this presentation, but I do not expect you to memorize them. The reason why is because there are some of them that are clinically relevant for some diseases that I'd like to mention. So first of all are the pyramidal tracts, which start in the motor cortex, because that's where the pyramidal cells are, or the BET cells, in layer 5 of the cortex. And the lateral corticospinal tract is the most important. It contains about, so 90% of the pyramidal tracts is from the lateral tract, and it controls the contralateral motor control of the limbs. And contralateral means that if it's on the right side, it controls the left-sided muscle. So if the right side of the brain says, hey, let's contract the muscles of the arms, it will contract the muscles in the left arm. And the reason why this is important to know is because this is affected in diseases like poliomyelitis and ALS, which stands for amyotrophic lateral sclerosis, which is a disease that causes deterioration of this pathway. There's also the anterior corticospinal tract, which is a lot smaller, and it actually mainly controls movements of the trunk and the proximal muscles, which are the muscles of the upper arms and upper legs. So they are the muscles that are closest to the trunk. Then there's the extrapyramidal tracts, which are other motor tracts that are not within or the cerebral cortex, but instead act from the brainstem or the spinal cord itself. And they are the rubrospinal tract, which controls fine motor functions, the reticulospinal tract, which controls muscle tone, the vestibulospinal tract, which controls posture, balance, and coordination, and the olivospinal tract, which controls coordination of the head specifically. Then there's the DCML and the spinothalamic pathways, or the pathway. The DCML stands for dorsal column medial lemniscus, and it's a type of sensory pathway by which you can sense fine touch and vibrations, and also proprioception. And proprioception is a difficult term we use for the recognition of your position. So it helps you with some degree of coordination. And then there's the spinothalamic pathway, which controls pain and arousal. Arousal about exciting situations, like getting a new car or attending one of my lectures. And it also controls the movements in the eye in the direction of pain. So when you have pain, you are often inclined to instantly look at the pain, which is automatically controlled by the spinothalamic pathway. Of course, you can resist the urge, but a lot of people cannot, and it's controlled by this pathway. And then finally, there's the spinocerebellar tracts. And the function of the spinocerebellar tracts, as you can mention, they are connected to the cerebellum, and they help with crude sensation in the arms, legs, and trunk, and therefore also positioning of these arms and legs and the trunk, all in relation to each other. So now that we've had that, we will actually cover the structure of a single nerve cell. So a single nerve cell consists out of a couple items that I've already mentioned before that we're now going to look at in detail. First of all, it has a nucleus or cell body, or this is so the nucleus is over here, but this entire part is what I mean, and it's called the cell body. It's also often called the neuronal body or the pericardium. And so this cell body is connected to, on the one hand, dendrites, and on the other hand, an axon. So the dendrites are the regions at which a neuron receives signals from other neurons, and axons are the paths through which the neuron actually sends their signals to other cells. And it does so through synapses. And a synapse is actually kind of a small gap between one nerve cell and another. And through this, they communicate by sending out either chemicals or sending out electrically charged particles. So very smart. And along this axon, you actually have the transmission of the signals. And so this transmission of signals depends on some form of electricity. And this electricity is what we call a potential. And the potential is measured in volts, typically. Now, what do you see here? Well, now here you see the normal concentrations, so the normal levels of different particles that are chemically charged, positively or negatively, and that are found outside of the nervous cell and inside of the neuron. So you can see that outside of the neuron, it's predominantly sodium and chloride. So sodium is Na, chloride is Cl minus. Sodium chloride, so if you put those two together, you get NaCl. Sodium chloride is kitchen salt, so it's essentially salt that's outside of them. And it has a little bit of potassium, which is the K. Now, inside of the cell, you have a lot of potassium, but you have only a little bit of sodium chloride. And this is a gradient. So the sodium and the chloride actually really want to get in because there's really little there, and there's a lot of them outside. So they kind of want to spread things equally. And the same thing goes for the potassium, which is what you call a concentration gradient. It's that the potassium, if there's a lot of potassium here and only a little bit potassium here, then it will try to move from here to here. But it's not allowed to do that because this is a thick barrier. And this gate can only be opened when the gate is stimulated. And this happens, for example, when a receptor is stimulated, for example, a pain receptor or a temperature receptor or a touch receptor or a chemoreceptor, which senses changes in the chemical composition of the blood, for example. So that's if that happens, these neurons will fire signals to other neurons. And what happens? Gates will open that allow for these molecules to flow. And because sodium and chloride are with so much, and because it's useful to allow them in first, they are allowed in first. So that's where you get something called an action potential. A potential is the electricity, and this is a potential, so an amount of electricity that leads to an action, whatever that action might be. So over here we have a foot that we're going to tickle with a little feather. And what happens is that from a resting membrane potential, so that's this in resting state, when the cell isn't doing anything, it actually goes up, the membrane potential, which means that the charge is positive now. And what happens is, or the reason why that happens, is because the sodium channels activate, which means that the sodium will go in. If you look at this slide, the sodium that's outside of the cell will move, not through this gate, but through a different gate. It will move into the cell because it really wants to get in there. And the sodium is very positive, and so it goes in. Whereas the potassium, although it has a plus, it's very negative because it still wants to go outside. It's something positive that doesn't want to stay here, but it wants to get out, so it works as a negative. So a lot of sodium will go in, so this potential or this electricity will go up. And when it goes up, it can actually fire the signal along the axon and transmit it to the next neuron, which we will discuss a bit later. But when this tip is reached, what you get is, is that the channels eventually deactivate. They say, well, okay, we've kind of had enough. So there's enough sodium inside the cell now as well, so we're going to stop. So these channels will close. But what happens is that the cell says, okay, I've had so much, I kind of want to go back to normal. So what it then does is that it opens the potassium channels. So these channels are opened and they move out in order to compensate for the sodium that went in. And then everything will become negative again. Everything will go out. And because the potassium channels are pretty slow in closing again, you get this small dip over here. And these processes are called, so this, when the graph moves up, is called depolarization. When it moves down, it's called repolarization. And when it moves actually below the resting membrane potential, it's called hyperpolarization. And over here, eventually everything goes back to normal. And the way in which a signal is propagated along an axon, in other words, it's transmitted along an axon, is not directly, or in most cases at least, it's not directly, because most nerves contain a sheet of myelin. As I said before, myelin is this fatty substance that's either secreted by the Schwann cells in the peripheral nervous system or by the oligodendrocytes in the central nervous system. And what happens is that because this is very fatty, it means that there can actually be no exchange of these sodium and potassium particles. And because of that, the electrical signal will actually just have to kind of jump along the axon. And it actually will jump, and which is something that we call saltatory conduction. Saltatory from the Latin saltare, which means to jump or to dance. So it's literally that the signal is dancing along this axon in order to get to the next nervous cell. And that's when you get the synapses. So the synapses are kind of, as I said, small areas where there's a very, very tiny cleft. In some cases, this cleft is very small or very narrow because you want to instantly have things pass through. And sometimes they're a bit bigger. So over here in synapse A, we have something called an electrical synapse. Because what happens is that the reason why one nerve cell can pass on a signal to another nerve cell is because the particles are actually instantly passed on. So the sodium that flowed into the first neuron can pass through here, and it can flow into this neuron as well. So that way you're kind of reusing the sodium for all the cells. That's an electrical signal. But there's also a chemical signal which uses something called a neurotransmitter. You've probably heard of that. And neurotransmitters are small molecules that activate small gates, and these gates actually are sodium gates. So what will happen is that this neurotransmitter substance is released when the charge of this neuron goes up during depolarization, and these neurotransmitters are released, and they actually bind on these small gates, and they open the gates for more sodium from the synaptic cleft to enter the cell. And after only a couple of milliseconds, so parts of a second, these neurotransmitter substances are degraded. So they are broken down. So there's a couple of sensory receptors in the skin that you also have to be familiar with that I also think are important for you to remember. First of all, there's the free nerve endings, which are rather superficial in the skin. And the free nerve endings actually transmit signals of pain and temperature. So they can sense whether something is hot or cold. And free nerve endings don't do this all at the same time because there are specialized free nerve endings for pain and also specialized free nerve endings for heat and specialized free nerve endings for cold. Then there's also the Merkel discs and the Pacinian corpuscles, as well as the Meissner corpuscles and the Ruffini endings. Those I think are most important. The Krause end bulbs and the root hair plexus are not important to know for now. So the Merkel disc, as you can see over here, is pretty close to the surface, typically speaking. And the Merkel discs are responsible for light touch, whereas the Meissner corpuscles are responsible for crude touch, and crude refers to deep touch. So deep touch to the skin. And then there's the Pacinian and the Ruffini, so the Pacinian corpuscles and the Ruffini endings. And the Ruffini endings are responsible for the light pressure, and Pacinian corpuscles are responsible for the deep pressure. Now, there's a difference between touch and pressure. Touch is, of course, when two objects touch each other, so when they slide alongside each other. And the force at which that happens is whether a touch is fine or crude. But pressure is when one object pushes into the other. So when you're putting your finger on your skin. That is felt by the Pacinian corpuscles and the Ruffini endings. Then there's something called nociception, which is essentially pain sensation. So pain is actually sensed by sensory nerves that are very inefficient because the sensory nerves in pain reception are unmyelinated, so they do not have myelin, which means that they are very slow. So you'll first feel the temperature, and then you will feel pain in case you're putting your hand into a fire. Over here we see an example. We see these are, this is an injury to, for example, a capillary over here that's in the skin because you had a scrape wound. And what will happen is that a sensory nerve will sense this, or it will actually be damaged in some cases. And as a result of that, it will send out a signal, a very, very screaming signal into the sensory system, and it will send it to the brainstem. And from the brainstem, there will be the brainstem and the cortex, by the way, it will send back a motor signal, either to contract the muscles that are underneath the skin here, which will make sure that you cannot bleed too much. So it will actually contract the muscles of the capillaries as well so that you do not bleed dead. It also contracts, for example, your muscles when you're putting your hand into a fire. So as a result of that, you will actually retract your hand and hopefully never put your hand into a fire again. So there we are, the reflexes for pain and temperature. I kind of already explained this, so I'm going to skip over this slide, but this slide is still pretty interesting to look at to understand how the reflex of pain works. And note that pain and temperature reflexes are typically spinal reflexes. So the nerve signal does not even have to travel to the brain, it just travels to the spinal cord, where the spinal cord will actually make sure that the pain is resolved. It doesn't have to be done by the brain all alone. There's also the spinal cord who can solve some problems. Then there's also the muscle spindle reflex, which is a type of reflex that responds to changes in muscle length. So when you increase the length of your muscle, when you change the length of your muscle, it means that you're either contracting or you're releasing your muscle. And your body has to kind of adapt to this. So there are sensory nerves that will kind of sense whether you are contracting your muscle, or whether you are extending your muscle. So you're kind of making it longer. And so when you contract your muscle in your arm, for example, by raising or lifting a weight, it will make sure that one muscle is contracted, but in response, the muscle on the other side of the arm, which is called the antagonist, is actually relaxed. Because otherwise, you have two muscles that apply tension, which have different functions, and actually functions that contradict each other. And if they were both to contract, then you wouldn't be able to move your arm. So then we have the Golgi tendon reflex, which is something similar to the muscle reflex, the muscle spindle reflex. Except the Golgi tendon reflex does not care about the length of the tendon, but it cares about the amount of tension there is on a tendon. So the most important, or the most commonly known, is the knee tendon reflex, which is where you, or the patellar tendon reflex, which is where you take a small Berliner hammer and you tap it on the region slightly below the patella, which is where the patellar tendon is located. And when you push onto this tendon with that hammer, it will elicit a response where it actually contracts the muscle so that the leg moves upwards. And it is to test certain spinal functions. So the control of this is controlled by of this reflex is by the spinal cord. And if a doctor suspects problems in, for example, your spinal cord, in case of a paralysis, they can do this reflex to test how high or how low the paralysis is located in the spinal cord. So now we have the autonomic nervous system again, and this will almost mark the end of this presentation. This is almost a 1-hour lecture. I hope you're still watching diligently and taking notes wherever you think is appropriate. So the autonomic nervous system is divided into two major subdivisions, again, namely the parasympathetic and the sympathetic division. Now we will cover them both individually. First of all is the sympathetic division. So the sympathetic division is also known as the fight or flight division. And what it does is that it has a couple of functions that are associated with, well, fighting or fleeing. So in other words, running. So the sympathetic division causes an increase in heart rate. It dilates your bronchi, which means that you can breathe in more air. It also stimulates sweat secretion, which is why during exercise, of course, you also sweat a lot, thanks to having an increased heart rate and more efficient breathing. But what also happens is that it relaxes your bladder, and your bladder, in order to urinate, will need to contract. So it will kind of inhibit urination, and it will also decrease storage of sugars in your liver, and it will also decrease activity of your digestive system. Now, the preganglionic fiber, or preganglionic nerve fiber, in other words, it's the nerve fiber that goes from the spinal cord to the ganglion. which you can see over here, which is, well, this is the spinal cord. So it's this very small green part here until the red bubble. It's very short. And this part of the fiber is myelinated, so it has myelin. Whereas the part that comes after, for example, from here towards the eye, is not myelinated. So you can see it only has a very small part where the transmission of signals is very fast, and this part is very slow. So even though this is the fight or flight division, the actions performed by the sympathetic division are rather slow. Does this matter? Well, not necessarily, because the sympathetic division, of course, increases your heart rate. So if you want to increase your heart rate, you can stimulate the sympathetic division. But as you'll see closely, the parasympathetic division is also known as the rest and digest division. So activation of the parasympathetic division will decrease your heart rate. But you can also stop those signals, and stopping those signals will get you a faster response to increase the heart rate than to stimulate the sympathetic system. So it doesn't matter, practically speaking. So over here we have the parasympathetic division. So the parasympathetic division, as I mentioned, is the rest and digest division because activation of this system slows down the heart rate. It constricts the bronchi, which means that although you can of course still breathe, they do not have to be very much expanded. So you will be breathing in rest. And it will also kind of constrict your blood vessels, or it can constrict your blood vessels in other regions than the muscles. Or actually in the muscles itself, sorry. So it decreases blood flow to muscles, and it increases blood flow to the digestive tract and the urinary system, because the parasympathetic system is responsible for urination and for the digestive system activity. So as I mentioned before, the preganglionic fiber is actually pretty long in the parasympathetic division. So it actually just starts over here, as you can see in the bladder, and it goes all the way here, and only at the bladder, there's only a very small postganglionic fiber. So the parasympathetic system actually has this very long myelinated fibers, which means they get very, very fast from here to here, and then they go very slowly, but only for a small part, which means that the actions by the parasympathetic division are faster. That's something important to know, because that might come back on an exam question. If you were to do your board exam in internal medicine, for example. So then we have a couple of receptors. So as I mentioned, there's the preganglionic and postganglionic fibers, of which the preganglionic is myelinated and the postganglionic is unmyelinated. What's important is that there are certain receptors, because neurotransmitters are released at these nerve ends. So typically speaking, this is acetylcholine. Acetylcholine is the most important neurotransmitter in the nervous system, and all of these nerve endings secrete acetylcholine, and the only exception is the postganglionic fibers of the sympathetic nervous system, which release epinephrine or adrenaline. So those are synonyms. That's the same thing. Or norepinephrine, also known as noradrenaline. More on all the neurotransmitters later, by the way. So here's another reflex that you have to be somewhat familiar with. A lot of this is also related to the physiology of the cardiovascular system. So the scheme on the right is something that we will discuss during that lecture. For now, you just have to be familiar with what's happening on the left side. So the baroreceptors are receptors found in the aorta, which is a large blood vessel connected to the heart, and the carotid arteries, which are blood vessels that directly stem from the aorta and go through your neck and towards your brain. And in the aorta and in the carotid arteries are baroreceptors. Okay, and what do these baroreceptors do? And these baroreceptors actually keep control of blood pressure. So they kind of check what the blood pressure is in your blood vessels at that point. And based on that, they will send more or less signals. Because if there's a lower blood pressure all of a sudden, they will increase their signaling, and that signaling is a sign for the brain to perhaps take some actions, like contract blood vessels or to increase heart rate. More on what the baroreceptor reflex actually means for the body in the lecture about cardiovascular physiology. For now, you have to be familiar with what a baroreceptor is, what its function is, and how reflexes work in general. There's also chemoreceptors. As I mentioned before, chemoreceptors actually measure changes in the chemical composition of the blood, and famous chemoreceptors are the chemoreceptors that relate to oxygen, carbon dioxide, and pH levels in the blood. So changes in oxygen and changes in carbon dioxide, which also cause changes in pH level of the blood, cause different stimulations of the peripheral chemoreceptors, which will cause an increase or decrease in ventilation. So that's what this system kind of looks like. You will discuss this system more during the lecture about respiratory physiology. And then we have the neurotransmitters. So over here you see an overview: adrenaline, noradrenaline, dopamine, serotonin, GABA, acetylcholine, glutamate, and endorphins. And the functions you can find below them are, in some cases, accurate, in some cases not completely accurate. Adrenaline is the fight or flight neurotransmitter, but so is noradrenaline. Noradrenaline is also associated with concentration, though to a lesser extent. It's mainly just a fight or flight neurotransmitter. Dopamine is a pleasure neurotransmitter, but it's not the only one, because so are serotonin and endorphins. Serotonin is also known as the mood neurotransmitter, and serotonin disorders are often associated with depression. GABA is also known as the calming neurotransmitter and also finds its, well, biological role in the incidence of depression. Acetylcholine here is mentioned as a learning neurotransmitter, which is to some degree accurate, but in practice we also see a lot of acetylcholine in contraction of muscles. So acetylcholine is also very, very important for muscle contractions. Then there's glutamate, which is associated with memory, and endorphins, which are associated with, it says euphoria, which is a type of pleasure, but it's a type of extreme pleasure associated with, for example, pain relief when treated with morphine. So here we have a couple of sympathetic receptors. So these are receptors found in the sympathetic nervous system, which are the alpha-1, alpha-2, beta-1, beta-2, and beta-3 receptors. And stimulation of these receptors by the sympathetic nervous system causes the different functions. So you can imagine, of course, like how does the sympathetic system actually cause this change in heart rate or this change in metabolism or in motility of the, in other words, movement of the intestines, and it's by means of these receptors. So the alpha-1 receptors are mainly responsible for contraction of the muscles in the blood vessels, ureter, and hair, among other locations, but these three, I think, are important to know. Stimulation of the alpha-2 receptors causes release of glucagon, which is a hormone we'll discuss later. Sphincter contraction, both the anal sphincter as well as other gastrointestinal sphincters, and the sphincter that's associated with urination. It also increases the risk of blood clotting, and it causes vasodilation, which is when the muscle in the blood vessels actually doesn't contract, but it relaxes. The beta-1 receptors cause a secretion of renin, which we'll discuss in the kidney physiology and cardiovascular physiology videos. Ghrelin, which we'll discuss with gastrointestinal physiology, and heart rate and stroke volume. Stroke volume is, for now it suffices to know that stroke volume is the amount of volume of blood that the heart pushes out when it contracts, which is about 70 milliliters of blood per contraction. And a beta-1 stimulation can result in an increased stroke volume, which means that the heart will work more efficiently. Beta-2 receptors are also pretty important because they cause muscle relaxation, typically in the blood vessels. Beta-2 receptors are found a lot in blood vessels. Insulin is also released by stimulation of these receptors, and it also causes lipolysis in adipose tissue, which essentially means breakdown of fatty tissue. And the beta-3 receptors are responsible for lipolysis in adipose tissue, so again, the fatty tissue, and also relaxation of the bladder. In other words, it stops urination. Now, contraction of the ureter, as mentioned with alpha 1, does not increase urination but decrease, because now the urine is unable to pass through from the kidneys through the ureter, and therefore the bladder won't get as full. So this was actually the entire video. It lasted for approximately 1 hour. I hope you learned a lot from this. Over here, you can again see an overview of the different learning outcomes we discussed. I'm not going to name them again. So thank you. If you have any questions, feel free to ask these in the staff medical chat, and perhaps see you another time.